we're going to move on to the next session now. So so we'll have what I would consider to be a very interesting session coming up with the next two speakers, who will share with us some difficulties they've had with some pelvic and acetabular cases. You've seen a lot of talks with a lot of really pretty slides and some outstanding cases, and obviously things don't always go exactly as we planned. When you're doing big complex surgeries, sometimes we have big complex problems as a result of that. And we've had a couple of very experienced speakers coming up who have agreed to share some of their difficulties and challenges they've had in the operating room, so that hopefully we can learn from things that they've learned in a little more painful fashion. So with that, I'll turn it over to Claude Sagi, who has a very large experience and has most all of his being outstanding good outcomes, but he's going to share with us a couple of difficult cases he had that didn't go so smoothly as he had hoped. So Claude, I'll turn it over to you.
Thanks, Steve. All right, we'll just get right to it. We'll see how horrible this turns out. This is a lady who was involved in a motor vehicle crash, and she has a sacral fracture, vertical shear with disruption of her anterior pelvic ring, as you can see here. And this is her CT scan cuts, and I think a couple of things that are interesting to note about this CT scan, if I just go back and forth here a little bit, are, clearly it's a vertical shear, and you can see that it has there's a large gap in the sacrum with, it's not impacted. It's obviously not inherently stable sacral fracture by any stretch of the imagination. You'd say that even perhaps the inferior aspect of the sacroiliac joint, as you go more caudally, is disrupted as well. And, these sorts of things often are accompanied by this. And this lady has this, flank ecchymosis. And really, this is just a marker for internal degloving on her, and is a horrible injury. And with this look at the soft tissue and this type of a fracture, the thing is, how do you end up taking all of this into consideration to try to come up with as close to an anatomic reduction as you can, and a stable reduction, in other words, that you can maintain with some sort of a fixation construct of your choosing, and not get into problems with complications. And, here are some of the mitigating factors for her that really, I think, made this difficult treatment decision for me. And, a vertical fracture, comminuted sacral injury, and this coronal clearly shows the disruption of the L5S1 facet joint, coupled with what looks like a bad soft tissue injury and internal degloving. And because of all of this, the decision really is: do you do an extensive posterior approach to try to reduce this anatomically and stabilize it, or roll the dice with the soft tissue, or do you try to mitigate those potential problems with the soft tissue injury and go for a less than perfect reduction and percutaneous fixation, and roll the dice there with hoping that you can maintain the reduction with your minimal fixation. And so I chose the latter because of concern over the soft tissues, and she had some other injuries that I thought were going to keep her in bed and really not mobilizing too much. But this is what happened within a week of the surgery. So we were happy to do an open anterior procedure and try to stabilize her percutaneously, and with a closed malreduction. You can see here, I put up on the left screen, this is not the resolution of the case, and this, believe it or not, is not the complication. So I'm trying to speed things up here, just showing you some of the key the key aspects of this case. But, you know, first mistake is, well, all right, Sagi, if you're going to try to do this percutaneously, you know, try to get a better reduction than that. And also, if you're going to try to stabilize such an unstable posterior pelvic ring with percutaneous fixation, why such chintzy posterior fixation, right? You can, it's a partially threaded screw to try to get some compression through the fracture, hopefully, but it ends, you know, the posterior fixation is hanging off just what, you know, 2 centimeters worth of screw or 3 centimeters worth of screw. You can see it broke, it's right where the fracture is. And so this fixation, I mean, inadequate is an understatement, obviously, for what I chose to do in this situation here. So, but now the question is, it's not like this is a couple of months and the soft tissues have had a chance to heal. This is only 1 week after the index surgery. The anterior pelvic ring is holding together, but this has clearly failed. And so now for me, the conundrum was, well, okay, do I have to somehow bite the bullet and now work through this soft tissue, or do we accept this malunion and in lieu of trying to do something heroic and end up with a really bad soft tissue problem? And of course, I decided to try to make it better. And this is her degloving lesion here. You can see how extensive that is. I mean, you could put your whole forearm into this wound right around her flank, is how badly she was degloved there. And put her prone, and this is what we ended up with in terms of the reduction. And here is how she ended up 8 months down the road. And the reason I'm showing this case in particular is that there are a number of, I think, judgment errors and technical errors that led to complications here that, well, you could argue could have been avoided or not, whether you decided to take a different course of treatment. But we'll just go dissect them here. And they're salient because of, I think, I brought it up because of this triangular fixation construct or unilateral spinal pelvic constructs and these very unstable fractures and the things that you can run into if you don't adhere to certain principles when you're doing it, soft tissue problems notwithstanding. So first and foremost is you can see, yes, there are now antibiotic bead chains in here because, of course, that wound dehisced, it got infected, and she wasn't healed. And that all happened early within a few weeks. So we had to debride that multiple times and put antibiotic bead chains in there to try to resolve her infection. Problem number 2, as you remember, there was that disrupted L5-S1 facet joint. And for me, that's actually an indication to do this type of a procedure. But what did I do wrong and not really take that into consideration? Well, I distracted, you know, because you can see this is not a good reduction of the sacral fracture. The left posterior pelvic ring is still cranially displaced. And it tried to distract across the spinal pelvic construct here, but instead of reducing the sacral fracture, all I did was further distract the L5-S1 facet joint. So a really important point to remember when you're doing spinal pelvic or lumbopelvic constructs, particularly if they're unilateral for unilateral vertical shear fractures, is that if you distract across this construct, you can distract the L5-S1 facet joint. And because the vector is also from medial to lateral and usually anterior to posterior, when you compare this point of fixation to that, if you distract across this construct, you actually end up displacing the fracture and gapping the sacral fracture, which causes a loss of reduction, and you end up with a non-union because you haven't closed the gap in the sacral fracture here. So you end up with a sacral fracture gap, and remember that sacral fractures heal in kind of a peculiar way. They, I guess they sort of spot weld, or you get certain areas where they fuse and other areas where they don't. They don't make abundant callus as a general rule. So you can't really expect the sacrum to fill this gap and overcome a malreduction, or, you know, if you have to try to compress if you can with a fully threaded, or sorry, a partially threaded screw rather than a fully threaded positional screw, which you can change out afterwards if you want to get, you know, thread purchase. That's really the issue, is not creating a fracture gap. So those are a couple of issues, I think, with spinal pelvic constructs that that you need to keep in mind so that you don't get these complications.
Great, thank you, Claude. I know it's very painful to relive a case like that when you go through it, because of the amount of time and effort you put into it and the number of surgeries. Going back through it is always painful. But in a couple of questions. One is, I know you have a lot of experience with spinal pelvic fixation, because that's you're spine trained as well. And it's nice to see that, you know, understand some of the complications that happen there. But question I would have is, in looking back at this case now in retrospect, at some of the decision points and where you diverted, what would you do differently, if anything, or is this just something that's inevitable with this type of injury?
Well, I would like to say the latter, of course.
And you might be right, by the way.
Well, and I think to some degree, maybe, but you know, I think with a case like this, you know, first of all, better transsacral screw, you know, fixation, you know, corridors notwithstanding, if you think that you can have them. This patient had corridors for more transsacral screw fixation. You can see here at S2 and S1, both are corridors for, you know, 2 transsacral screws at 2 separate levels. So I think 2-level transsacral screw fixation. And, you know, in this situation, I honestly, as much as I'm not a real fan of the construct, I actually think it's like transiliac plating posterior. It's not really a tension band in this particular scenario, but that type of a construct would have been nice, because you can do that through a much smaller exposure and less of a soft tissue insult to the patient. So if I go back and look at this, if I had to relive this whole case, I would do 2 full-length transsacral screws, one in S1, one at the second sacral segment, and then a posterior tension band construct for this one.